Today, I have the distinct pleasure of having a conversation with Dr. Carol Haywood. Dr. Haywood is Assistant Professor of Medical Social Sciences at Northwestern University Feinberg School of Medicine, and her active research is focused on access and quality of healthcare for people with disabilities, including medical education for disability competent healthcare. So thank you so much for joining with me. I'm very eager to have this conversation with you and to share our conversation with stakeholders who are interested in the topic of healthcare for patients with hearing loss in particular. So a
Thanks for having
while,
me, Peggy.
it's great to have you. A while back, we had a conversation, and you said something that struck me as so foundational to this topic that I actually wrote it down, and I'm going to read your statement. You said that providers largely tend to be unprepared for how to work with disability when it's not something they are charged with healing. So, can you tell us a little bit about your research and what you found in that realm?
Yeah, thanks for this question. And it's really an honor to be here and have this conversation with you. Um, I'm going to take us maybe on a little bit of a journey to talk about the research because I think it's helpful to have some perspective of how I came to be someone who studies medical education. I started by really being interested and focused on patient experience. What were people's lived experiences of accessing healthcare, and what were their experiences with how that healthcare went? Did it serve their needs? Did it help them feel, safe and strong and get the outcomes that they were looking for? And increasingly, as I was doing that work, we started thinking more and more about what were the factors that might be contributing to gaps in healthcare access and frustrations or challenges in getting the care that people wanted and needed. And so we started looking more at physicians and how physician readiness might contribute to the types of care experiences that people have. And if we further kind of trace that upstream, eventually that brought me to the space of medical education to say, how are physicians actually trained? How do they learn about disability? And how does that training in disability ultimately influence the ways that they work with patients in the care environment? What we have learned through both formal research and more informal collaborative work is that in most cases, medical training does not focus on disability as a way of living. Medical education focuses instead on disability as a negative health outcome, so something related to illness or disease. And physicians think about disability as something that they should be preventing or eliminating within the care. And so they're trained to kind of look for and evaluate disability in a way to minimize it. When they see disability, they think of that as something that needs to be adjusted in medical treatment or something that can, they're looking for opportunities to reduce the disability. Beyond that, they're not really learning about disability. So they're not learning that disability can be part of people's lived experience, that it can just be part of the human condition, of the diversity of our human condition. And what this means is that if it's not the reason that someone is seeking care, it's not something that they're learning to focus on. So when someone with hearing loss, for example, goes to the doctor because their throat is sore or because they hurt their arm, if the reason for coming to the care environment is not because their hearing has changed, the doctors aren't really thinking about hearing. They're not trained to communicate with someone effectively who has hearing loss. And so it's become, a real barrier for physicians who are trying to partner with patients in the care setting. If the hearing loss is not the focus of the encounter, they don't know what to do with it. And it can be quite frustrating, actually. Most of the time, they don't know that someone who's arriving for the visit has hearing loss or a different type of disability. And when they realize that that's happening, they have to quickly kind of think, what do I do about this? How do we adapt care? And without the proper training, they often don't know how to adapt care. And they're under so much pressure in the healthcare system to keep going, right? The pace of care is very quick. And so oftentimes they don't have time to pause and be creative and collaborative in the clinical encounter in ways that could be more accommodating and affirming to people. And so instead of pausing to talk about effective communication strategies, they just continue to push forward in the clinical encounter because they don't know how to do it otherwise, and they don't have the tools or resources to do it otherwise. So that's a really long form answer to kind of get at this
No.
real gap in medical education that ultimately has a big impact on how people experience care.
So it's so interesting because I think what you're saying is that there's no mindset about the primary importance of communication. Or maybe there is, but if you are talking to a patient who has hearing loss, and maybe it's even a patient who's pretty savvy and has requested aids and services, if it's not in your bandwidth, if it's not in your mindset, there might be, I mean, I've had a couple of situations where the provider just would not cooperate with my request for accommodations. Eventually, one of those providers, who was a really very patient-centered care physician, heard me, but I had to really work at it and go back and sort of teach him, educate him about what hearing loss meant in a healthcare encounter and also what I needed. So it's really fascinating. And I think that like what we're learning is that this is something that doesn't just impact the patient, it impacts the provider because most providers want to make their patients have a good health outcome, help their patients to be healthy. But the complication of difficulty hearing makes the whole thing sort of much more complex for the provider. So it sounds sort
Yeah,
of
absolutely.
like the role of the patient in educating the provider becomes much more important, at least at this stage of the game. So I have another question about this, and that is that if you were to describe the model curriculum for healthcare providers, does that already exist, and what would it be?
Yeah, I think ideally the curriculum should include disability at every stage and kind of across different clinical foci. So what that means is that the first 2 years of medical school are preclinical years. Students are primarily in a classroom. They're learning about physiology and pathology, and oftentimes this is a space where they're not hearing about disability, except when they're hearing about it as a negative consequence of disease. If we could start early and introduce disability as a way that people exist in the world, as a way that, they navigate the world, this is a space to normalize ideas about disability and help people understand that their patients are going to look really different. One of the challenges in medical education right now is that the training is highly standardized around what we might call a quote unquote normalized body. Uh, that's a different conversation for a different day of what a normal body looks like and functions like. But I think we can probably imagine pretty well that like a normal body is not how most of us exist in the world. And so physicians are kind of learning particular ways of body functions and body structures. And if they could learn earlier about the variations of body functions and structures, that would normalize ideas of disability. And then going into clinical years, which is the latter half of medical training, if they can take those ideas that have normalized diversity in the ways that we exist in the world, if they can take those ideas and create more curiosity and have more opportunities to interact with people who communicate differently, who move differently, who view the world differently, right? If they can
Yeah,
interact with these types of individuals in their training environment with safety and support of their faculty and mentors who will help
yeah.
them develop language and develop skills for effective communication, for example, then they'll be much more confident coming out of medical school to work with individuals in all kinds of settings. So
Sounds
often, yeah, go ahead.
No, it sounds really fabulous, and it's a very exciting idea. That, I mean, I think of hearing loss as not such a big deal until I don't have access. And,
Mm.
so there are lots of things that a person with hearing loss can do to make a situation accessible. And it's great until it's not, until there is no access. And so to have it not be such a big deal by giving physicians the kind of training that they need would just be wonderful.
Yeah. If I can briefly share a little bit of a idea here. So the way that I think about disability is that there's a misalignment between how someone's body functions and what the demands of their environment are. And what you're saying is exactly this. Like oftentimes with hearing loss, it's not a problem until it is, right? Until the environment makes it so. So many people, including people with hearing loss, have adapted skills and tools and technologies that allow full independence and activity in their everyday life. And so hearing loss in and of itself doesn't need to be disabling. It does not need to be a disability. But healthcare is one example, unfortunately, of an environment that can be very disabling for
Yeah,
people.
yeah,
If we
and can
don't
lead.
support the communication, it leads to
Absolutely,
experiences of disability and
absolutely.
and poorer health outcomes. And so really thinking critically about how physicians can be a partner in uh, creating accessible care is very important.
Well, this is so informative. And I'll just tell you that one of the things that Tony and I have been thinking a lot about is creating, I mean, I think of it as almost like a curriculum for patients, even though it's not supposed to be the role of the patient to teach the provider. I think that there are ways that we can go about it that can create real collaborations with our providers. And we also think of it as like a continuum of advocacy practices, starting with forging a conversation and a relationship with the providers and with the healthcare systems. It's a lot of work. It requires a lot of diligence, a lot of attention. And then at the far end of that skill set is the notion that if a provider, and I think it's somewhat unusual, at least it has been in my experience, unusual that a provider just won't budge or that a healthcare system won't budge, then there are other measures that patients need to be skillful in adopting and implementing. I could talk to you for the next 4 hours about this topic, and hope I do
Yes.
someday. But I will say that thank you so much for meeting with me, and we're going to be very interested in sharing this information with our constituents.
Thank you, Peggy. It's really important work. Thanks for all that you do.